Hi everyone. I hope I am audible. There is a chat window here. Anything you all want to put up in between, please feel free to do that. If the audio and video are clear to you, please just send a hi across in the chat so I know that we are good to begin. Just a moment. Okay. Very good morning, all of you. I'm glad that this Sunday morning I have you all with me today. We are going to be talking a lot today. We are going to be talking about one of the most ignored aspects of endodontics. And I say one of the, when we are in dental school, we are always told that achieving profound anesthesia is important, but then there's always this little bit of a doubt as to how important really your obturations are. There have been several number of articles where they have told us that teeth which have not been obturated, which are without an obturation, can also survive for a very long time. And then I come in front of you today and I talk to you about three-dimensional obturations. Well, is it really that important? Let's really delve into this and see what exactly we are talking about. I'm Dr. Haren Shah. I'm a practicing endodontist from Mumbai. I've been practicing for about 8 years now, and teaching is my passion. I will be putting up my telephone number, email address at the end of the presentation. In case there's ever any difficulty, please feel free to get in touch with me. Let's talk about obturations. So we all see that there are beautiful obturations that people post on Facebook. Well, by the way, all the cases that I show in this presentation are going to be my own cases. They are not from any other social media or from any other friends. If I'm using any slide from a friend, it will mention courtesy to Dr. So-and-so. So whatever obturations we do these days, or whatever obturations we are seeing online these days, a lot of them start giving us complexes. What we really need to understand is these obturations are only white lines that we are seeing. We are not seeing the kind of cleaning and shaping that the particular doctor has done, or the kind of effort that has gone into the case. So sometimes it's very easy for us to just pass a comment when we see an obturation which is not that well done. We straight away assume that the doctor has not done a good job. What we fail to realize here is the doctor probably put in the best effort that he could, and still he could not achieve ideal results. And this can happen with the best of us. How much ever hard we are struggling to do our cases, there is always going to be a time when we don't achieve the results that we desire. So when you talk about complex anatomy, I'll just give you a small guideline here. Yeah. So what I'm talking about is very often we see teeth which have these kind of J hooks in the apical third, especially mandibular molars, distal root. This is almost quite common. Maybe not up to this degree, but having apical curvatures in mandibular molars is obviously very common. Then there are these young permanent molars. If you can make out, this is a very young girl here. This is a stainless steel crown that we've given on top. Wide canals, short roots. So these are the kind of cases that we are talking about. We always keep feeling that the particular doctor may or may not have done a good job. And then there is also this question, these particular white bands or white blobs that you see around, are these really necessary? Do these indicate success of treatment or they don't? Just giving you some samples of obturations. This is a mandibular first molar with extremely long roots. These were about 27 millimeters in the distal canal. And our aim always remains the same. We want to reach up to the apical terminus and we want to have a good three-dimensional seal. These are mandibular first and second molars. You can easily make out that there are two canals in the mandibular first molar. There is also a lateral exit here. So what I'm going to be talking about with to you today is how to fill these areas. See, filling the main root canals is extremely easy. Filling the entire root canal system is what is complicating. If you pay a little bit of attention onto this molar, you will be able to make out there is a tiny lateral canal here somewhere in the middle third of the mesial root. There is also some apical delta, multiple portals of exit in this mandibular first premolar. So these are the kind of obturations that we are talking about. We are not talking of regular obturations. Obviously, I'm going to be taking you through a lot of questions that we'll be dealing, like why do we need to obturate? How do we obturate? When do we obturate? Let us see some questions like that. This is another mandibular first molar that you see here, huge distal cavity. We start with the working length. We discover 3 canals in the mesial root and 1 in the distal root. This is the master cone radiograph that you can see, and this is the final obturation. I don't want you to appreciate the fact that there are 3 canals in the mesial root. The reason I put this radiograph is because of this anatomy here. Similarly, you can see there is a apical delta in the mesial root as well. This is an angulated radiograph of the same tooth again, and you can clearly appreciate the filling of the apical delta. Now, like I told you, we'll be coming to a lot of questions. So let's take the first question. Why do we need to obturate? There have been several studies which say that they have tried keeping teeth only after cleaning and shaping, and they have put a permanent restoration without obturation. Some of these will also tell you that this particular treatment modality has been successful for them, but most of them say that this does not last. So the primary reason that we obturate teeth is because we want to have a airtight, fluid-tight seal in the apical end as well as at the orifice of the canal. We want the root canal system to be totally obliterated. Why? Because whenever you're doing your cleaning and shaping, you can never be 100% sure that you have cleaned everything out. There are going to be some bacteria, some bacterial byproducts, some toxins which are still left inside the canal. Now, you don't want these bacteria and bacterial byproducts to come in contact with the rest of the anatomy. You want them to be isolated and sealed. For this seal, you require to obturate. Another reason for obturation is when you leave your root canals completely empty without any obturation, it is a hollow space right in the middle of the tooth. So when there are forces on the tooth, there are higher chances of fracture. There are quite some studies which have shown this, that once gutta percha is used for obturation, the strength of the tooth increases. These are basically the reasons why we obturate. See, this is another mandibular first molar with 3 mesial canals here and 1 or 2 distal canals, which are right now not seen in this particular image. This is the final obturation radiograph of the same patient. You can clearly appreciate 3 canals in the mesial, probably 2 canals in the distal. So the next question is, till where should I obturate? Because we've all been told that your obturation should be right up till the working length, right up till the working length. Some people will say it should be kept 1 millimeter short of the working length. Some will say 2 millimeters short of the working length. So let's see exactly till where we need to work. If you can understand this diagram clearly, I'll just show you what I'm talking about. Now, obviously, this is the dentin, this is the cementum, and this is the PDL, right? Clear so far? Yeah. Now, let's talk about this. This is the periodontal ligament, and whatever is present inside the tooth was the pulp, right? Where is the junction between the pulp and the periodontal ligament? The junction is the cemento-dentinal junction, that is this particular point here and this particular point here. So what I'm saying is all the tissue that is present till this extent must be cleaned out. Whatever is present beyond this should be left the way it is. Why do I say this? Because the aim of your endodontic treatment is to extirpate pulp, not the periodontal ligament. So what I mean by this is, and now there is one tiny problem with this as well. The CDJ or the cemento-dentinal junction is not a clinical entity, it is a histological entity. You cannot see the cemento-dentinal junction. So because this is a histological entity, we try to clinically correlate it with some clinical facts. Like what? This cemento-dentinal junction generally coincides with the minor diameter of the tooth. Now, what do I mean by the minor diameter or the apical constriction, which is alternatively called as? The The apical constriction or the minor diameter is the narrowest portion of the root canal in the apical third. So obviously, if you see this diagram, you can make out that the narrowest portion is going to be in this region, correct? So which is precisely what I'm talking about. This is where your cleaning, shaping, and obturation should end. Then why do we say it should be half to 1 millimeter short of the radiographic apex? Because on your radiographs, the cementum also appears to be a part of the root. So your radiograph is going to be till here and your obturation will be till here. Most studies have shown that this distance is approximately 0.5 to 1 millimeters, which is why we keep our obturation half to 1 millimeter short of the radiographic length. Now let's relate this to the apex locator, because radiographs is not all that we want. Now when you're using an apex locator like this is an eye root by the way. So when you're using an apex locator like this, you start putting your file down and the apex locator keeps giving you particular readings, right? You are supposed to stop not at 0.5 but only and only when you reach 0.0. 0.0 is the point where you want to take your apex locator reading up to. Why? Because this 0.5 does not really mean half millimeter short of the apex. You can go and check your own apex locators. No apex locators will give you readings in millimeters. You see, they don't write 2 millimeters, 1.5 millimeters, 1 millimeter. They will only write 1.5, 1, 0.50. Make sure to take your file right up till 0 and only then estimate your working length. So where should my working length be till? See, what you should basically be doing is you take your file up till 0, adjust the stopper, take the file out. Once you've taken the file out, you'll measure it on a ruler. Whatever reading the ruler gives you, you will reduce half a millimeter from that and you will assume that to be your working length. Let's move ahead now. Yeah. So there is this one tiny question I want to ask you all. Will you be obturating a tooth which has a draining sinus? Because my next question is going to be, when do we obturate teeth? So one question I'm asking you before going to when do we obturate teeth is, will you obturate a tooth which has a draining sinus? Dr. Roxon will be putting up a poll for you. I'll wait for a couple of minutes for some answers to come in, and then we will continue with the presentation ahead of this. Can you obturate a tooth which has a draining sinus? So I have some readings in front of me. We are almost at 50-50, 55-45. Come on, guys. We need more numbers here. I need a definite answer, right? A patient comes to you, he has an abscess on the side in the vestibule somewhere, which is, you assume that it is associated with a particular root. You do sinus tracing there by putting a gutta percha point. Then how do you decide whether I'm going to do a single visit root canal for this patient or do I need to give a dressing? I have more than 130 people here, and the answers I have right now are in the range of 53-47. So 54, 52, 51. Okay, so I assume that we are biased about this. We don't have any particular short answer to this. Now, let me just explain this particular scenario to you. What happens is when you have a, okay, so finally we have stopped at 50-50. So that's exactly half of the people who feel that we should be doing an obturation for a tooth which has a draining sinus, and half of y'all who feel that we should not be obturating this tooth for now. Now, when we talk about obturation of a tooth which has a draining sinus, what I want to tell you here is, whenever a tooth has a draining sinus, please realize that this particular tooth is also going to have some place where all the infectious can drain out from the root canal. Because of this, it is 100% safe to obturate this tooth on the first day itself. That is, you can easily perform a single visit endodontic treatment. You do not need to give a dressing. So let's look at cases that can be obturated and cases that you should not be obturating, right? Now, some of these are only textual answers and they don't hold true in today's scenario, but I'm also going to tell you what is practical as of now. Teeth which are asymptomatic can be obturated. So patient is not complaining to you about any swelling, not complaining to you about any pain. So you are safe to obturate these teeth. If you can get a dry canal, if you can clean out all the exudate from the canal and the canal is completely dry when you insert a paper point inside, you can safely obturate the root. If there is any foul odor that is emanating from the root canals or from the pulp chamber, it indicates sign of active anaerobic infection, which is why you should postpone your obturation and you should not do the obturation on the same day. The temporary restoration that you had put in the last appointment should be intact, because if the temporary restoration is dislodged, what happens is the saliva from the patient's mouth, it enters the root canal, it enters the pulp chamber, and there are chances of infection again. And you should have a negative culture from the root canal. What this means is, historically, what people used to do was they would take a paper point after completely, after finishing their cleaning, shaping, drying of the canals, they would take a paper point, put it inside the canal. They would send these paper points to a laboratory and they used to culture the paper points. So in case there is bacterial growth, they would not obturate, they would give dressings. But this is a very time consuming process. So some in-clinic culture systems were also introduced, but by far they've not picked up popularity. So from my experience and what I have read, I would like to tell you that if you have a canal which is dry and there is no foul odor, please feel free to obturate. It is okay if the patient has slight amount of pain. It is okay if the temporary restoration is dislodged. But if you have a canal which is not moist at all and if there is no foul odor, you can safely obturate this canal. One third condition where I would say you cannot do a single visit endo or you should not do a single visit endo is cases of re-root canals. Because in retreatments, the kind of bacterial flora in the tooth is very different. And your routine irrigants cannot take care of these bacteria. So you need to give a dressing of chlorhexidine so that all the bacteria are taken care of. But this is a completely different topic. I'm not discussing that right now. What I want to tell you is the only 3 cases when you will not obturate on the same day is if you're doing a re-root canal, if you cannot have dry canals, that is the canals are weeping or moist, and if you have foul odor coming out of the canal. Sometimes, you know, when you remove the temporary restoration, the patient tells you, doctor, I can feel something stinking inside the mouth, or sometimes even you can sense it. These cases, please don't obturate on that day. Okay, so let's move on to the next topic. Let's assume you've done your cleaning and shaping thoroughly. You've completed the entire irrigation cycle and now you're good to obturate. What are you going to do? You will take a master cone radiograph. You will take your GP points, put them inside the canal, and you will expose a radiograph. There are some things that I want to tell you about these radiographs as well. Sometimes what happens is when you have put these GP points inside, they might go slightly outside your root canals radiographically. Correct? So let's discuss what to do if they go beyond, what to do if they are short. So in case your master cone is extremely loose inside the canal, there are 2 things you can do. Either you cut 1 millimeter from the tip or you start putting accessory cones. These are the only 2 things you can do. Another scenario is if the GP point is short of the working length, it does not go to the prepared working length, you should select a smaller cone. If the smaller cone also does not go till the full working length, you need to refine your root canal shaping. So you use your master apical file one more time and you make sure that your master cone goes to the complete working length. And sometimes, like in this case, you can see the master cone goes slightly beyond the working length. In such cases, the situation is very simple. You can either cut this point a little bit and then repeat your radiograph, or take a cone which is larger in size and can go up to the adequate working length. What you need to be sure is about the tuck back that you feel. So let's talk about what exactly this tuck back is. See, what happens is when you're preparing your canals, sometimes you feel that you are going up to the full working length, but the GP point is not stiff inside the canal. You don't feel resistance from the walls of the root canal. And if you do not feel resistance from the root canal walls, it means that the GP point is very loose inside the root canal. Whenever a gutta percha point is loose inside a canal, it is not the right decision to obturate as it is. Because what happens is, in case, let's take just this GP point for example. Now here, if you can see in the apical third, the GP point is snugly fitting inside the root canal. If this was not the case, what would happen is, when I start obturating and I apply a little bit of pressure on the master point, my GP point will get pushed beyond the root canal. So it's very important whenever you're taking the master cone radiograph, you should literally push your GP points as much as you can during the radiograph itself. I see a lot of people being worried about if I push my GP point, it will go beyond in my radiograph. It's okay if it goes beyond in this master cone radiograph because you can still adjust it. If it goes beyond after your obturation, it becomes extremely difficult to retrieve the gutta percha back. Another couple of points about tuck back I want to make is sometimes what happens is, especially when you are preparing your canals up till 6%, you get false tuck back from the coronal or the middle third of the root canal. However, the apical third does not give you tuck back. The only way to be sure that you have tuck back from the apical third is if you have prepared this particular canal with a 6% rotary file, you make sure to obturate it with a 4% gutta percha, which means there will be dead space in the middle and the coronal thirds, but the apical third, the GP will be snugly fitting and you will have adequate tuck back. This dead space in the middle and the coronal third may be filled with any other techniques like lateral condensation or continuous wave condensation or thermoplastic obturation techniques. That is not our concern. Our primary concern is the tuck back from the apical third of the canal. So after we've spoken about the master cone radiograph, obviously the next thing that we need to talk about are the kind of sealers that we are using. Now, whichever type of sealer you use, the first point to note here is your sealer has to be used in minimum quantity. I see people mixing a lot of sealer, coating the entire gutta percha point with sealer. Even if you pick up the GP, there is a sealer that is dripping down. This is not the right way to use your sealer. Your root canal anatomy has to primarily be occupied by the gutta percha points, and only the spaces between the GPs should be filled by the sealers. Now, when we talk about sealers, there are various different types of sealers that are available to us, like you all know. The first and the most common one that we use is zinc oxide eugenol based sealers. Now, the important thing to note here is that zinc oxide eugenol based sealers are completely different from the zinc oxide eugenol cement that you use. Those big bottles that you get, you mix them for your temporary restorations or for some other things. These sealers are zinc oxide eugenol based. They are not zinc oxide eugenol cement. They have some additional properties. The solubility of these sealers is quite low compared to the ZOE cement. So please make sure if you're using a ZOE based sealer, purchase a separate sealer and don't use your zinc oxide eugenol for obturations. The most popular ones in this category are Pulp Canal Sealer, EWD, which is from Cybron Endo, that is Kerr. Then you have Tubely Seal, which is a tube-based zinc oxide eugenol-based sealer, which is also from the same company. Another favorite is Endomethazone, which is from Septodont, which is also a ZOE-based sealer. Endomethazone also has a few extra ingredients. Primarily to note is the steroid component that it has. The earlier versions of endomethazone also had paraformaldehyde, but obviously now because paraformaldehyde is not allowed anymore, they have completely removed paraformaldehyde from the composition and they only use steroids. So a few things about ZOE based sealers is these sealers are, trust me, they are the gold standard of sealers. They are seriously the best quality of sealers that you can get. The reason being that the film thickness is extremely less. You can get the perfect consistency when you mix it and you raise that spatula from your mixing pad or the glass slab. You can see a 1-inch string of the sealer, which is why I love ZOE based sealers. But these ZOE based sealers cannot be used in every scenario. Why? Because there is eugenol. As we know, eugenol interferes with bonding. So if you are planning to give a fiber post in a particular canal, you cannot use a zinc oxide eugenol based sealer because these fiber posts need to be bonded with resin cements. Resin cements are nothing but modified composites. Composites cannot bond to a eugenol treated dentin. The bonding is very weak. So we don't use ZOE based sealers if you are going to put a fiber post. Another important thing to note is whenever you have a ZOE based, whenever you're using a ZOE based sealer, make sure to clean the entire pulp chamber thoroughly. Any remnants of eugenol in the pulp chamber will interfere with the polymerization of your composite restoration that you do after the obturation. So that's all about zinc oxide eugenol based sealers. Next, I want to talk to you about calcium hydroxide based sealers. Now, When we talk about calcium hydroxide based sealers, there's been a lot of talk about these sealers because Seal Apex from Cybron Endo especially had gotten extremely popular. But a lot of people had their reservations because this contains calcium hydroxide. It has more dissolution. It will show more solubility, and then the canal will not have any sealer at all. So I'll just like to clear a little bit of air. Now, these calcium hydroxide based sealers are actually present in a resin matrix. They are suspended in a resin matrix, because of which the solubility is not as high as some people think it is. Another important thing is these sealers, because they contain calcium hydroxide, they have a continuous release of calcium ions, because of which some studies have shown that the chances of infection are reduced. So the two most common calcium hydroxide based sealers are Apexit Plus, and which is from Ivoclar Vivadent, and Seal Apex, which is from Cybron Endo. The third kind of sealer that I want to talk to you about are the resin based sealers. Now, resin based sealers have got their own advantages and disadvantages. These are the perfect sealers for me whenever I want to put a fiber post into the tooth, because it's a resin. It's not going to interfere with the bonding or polymerization of my resin cement. The popular sealers in the resin-based category are obviously AH Plus, which is from Dentistry. Then there is Seal Max R, which is from Mark Products. So these sealers, they are extremely good in quality. They have all the properties that you like, but somehow there is a lot of reservation about using resin-based sealers, because the first point is resin-based sealers are extremely difficult to retrieve from the root canal. For a resin-based sealer, you need, in case you have to do a retreatment for a tooth in which you have done an obturation using, say, AH Plus, for example, you may need to use a different kind of gutta percha solvent altogether. Why? Because your regular GP solvent cannot dissolve resins. It can only dissolve the gutta percha. So you need to use a different kind of solvent so that you can also soften the resin sealer that you're using. Another disadvantage is that these resin-based sealers, probably because of the humidity and heat in our climate, the Indian climate, what happens is they seem to be of a very runny consistency when you mix them. And then after a few moments, it immediately sets into something which is very thick. So what happens is, to know when exactly to pick up the sealer and put it in the canal, it becomes kind of a challenge. So because of these, and the third important reason why people are not using resin-based sealers is the cost, because these sealers are a little expensive compared to the other sealers, and the consistency is not ideal when you use it in our scenario. Now, after the resin-based sealers, what has been picking up the most is bioceramic sealers. Why do I talk about bioceramic sealers? What is so special about them? Now, these bioceramic sealers are basically of three types. There are sealers which are based on calcium phosphate, there are sealers which are based on calcium silicate, and then there are MTA based sealers. What exactly do I mean by a bioceramic sealer? See, bioceramic sealers are sealers which have these calcium phosphate or calcium silicate or trisilicate particles, and they are extremely biocompatible. How this helps basically is, if a sealer is so biocompatible, it does not matter if it gets extruded outside the root canal. Plus, a lot of these sealers have osteoconductive and osteoinductive properties. So what they do is, once they are at the apex, they ask the PDL to bring about healing. So the PDL and the bone around the tooth, the healing properties of these bioceramic sealers are extremely good. Examples of bioceramic sealers are MTA Filapex, then you have Cerasil B, you have Cerasil RC, you have sealers like, see, you can see Cerasil RC here, you have Endosequence BC. So there are so many different kinds of bioceramic sealers. You also have something called as Gutta Flow Bioseal, which is a combination, which is basically a bioceramic sealer, but they've also incorporated gutta percha particles into the sealer itself. So it becomes a monoblock when you obturate the canal. Anyways, moving on, talking about bioceramic sealers. These sealers are my favorite for all kinds of complex cases. What I mean by complex cases is, whenever I see a large periapical lesion, I will always obturate using a bioceramic sealer. Another indication for these bioceramic sealers for me is whenever there is a perforation anywhere in the root, I will always use a bioceramic sealer with my gutta percha point, because the perforation repair which I'm carrying out with MTA, my bioceramic sealer and MTA go very well hand in hand, and they are good friends. So basically, there's not going to be any interface between them, any leakage between the MTA and the bioceramic sealer. So if you feel surprised to see this slide, what is disinfection of gutta percha points? See, the reason I'm putting this here is what happens in your practice is when you have a particular patient, you take a master cone radiograph. After the master cone radiograph, what happens is you are busy seeing the radiograph, the gutta percha is in the patient's mouth. Or even when you are taking the radiograph, the GP is basically swimming in a pool of saliva. Sometimes you remove the gutta percha point from the tooth and you drop it down. And very often what you do is you pick up that GP point and you use it for obturation. This is not the right thing to do, because what happens is you have made the canal, you have cleaned and shaped the canal as effectively as you could. The canal is close to sterile. In this sterile environment, if we introduce any external bacteria, they are going to multiply very fast. This is one of the reasons why after obturation, the patient, even though the obturation looks perfect on your radiographs, the patient still complains of pain. Now, another scenario is you use a tweezer, right, to take the gutta percha points out of the box. Now that box, when it came to you, it was packed, it was sterile. The moment you opened it, it has turned non-sterile. Plus, you are using a tweezer which was used for handling the patient's cotton rolls and God knows what all. And then the same tweezer goes inside the box of gutta percha points. How do you expect these GP points to still remain sterile? So it's important that after the master cone radiograph is taken, you should disinfect the gutta percha points. So the next question is, how do you disinfect these GP points? The way you do that is, you dip your GP points into a dappen dish which is filled with sodium hypochlorite. You will keep the gutta percha points in this sodium hypochlorite for approximately 1 minute. What happens is, after you've removed the GP after 1 minute, once the hypo dries off from the gutta percha points, there are some salt deposits on the GP points, which you need to rinse. How do you rinse it? You just clean your GP points with alcohol or spirit. If you find this procedure very complicated, there is another simpler way to do it. You use 2% chlorhexidine. Just use it for a couple of minutes. You can take a gauze piece, which is basically flooded with chlorhexidine. You put all your 3 or 4 GP points in this gauze piece, close the gauze piece, leave it as it is for 2 minutes, remove and straight away obturate. You don't need to rinse this GP point. So these are 2 simple and effective ways of disinfection of your gutta percha point before you actually obturate the teeth. Which brings me to the next point, that is the obturation materials and techniques. See, there's not much to talk about the materials because I don't want to go into the theoretical and historical interest points such as paste obturations or silver points and stuff. So what we'll be talking about in obturations basically is the kind of techniques that you can use for obturation. I'll tell you 1 or 2 sentences about each of these techniques so you have a rough idea, and then we will explain in detail only those techniques which are still popularly used. So talking of obturation techniques, the first obturation technique I want to talk about is lateral condensation or cold lateral compaction, which is basically lateral pushing of the gutta percha with the use of a spreader. I'm sure all of y'all have performed this particular obturation technique at some point or the other. What you do is you take one master gutta percha, you put a spreader inside to create space for accessory gutta perchas, and then you keep inserting accessory GP points. The next technique is the vertical compaction technique, which is also called as warm vertical compaction. What you do here is, the gutta percha that you've put inside, you will take a heat source, heat this gutta percha, and you will start pushing it vertically. It's very important that you have good apical tuck back in these cases to make sure that the gutta percha does not get pushed beyond the canal. I will be discussing this in more detail. Obviously, continuous wave condensation is only a modification of the warm vertical compaction. We'll see a video for the continuous wave condensation technique also. Then there is warm lateral compaction. It is same as lateral condensation. The only difference is the spreader that you introduce inside the canal is heated before it is put into the canal. Because of this heat, the gutta percha inside, which is thermoplastic, it melts slightly and it starts flowing. The next obturation technique is the injection technique, in which either hot or cold gutta percha are directly injected through a syringe. We will see both of these techniques in detail. Thermo-mechanical compaction, or if you remember, there was something called as a max pattern compactor. What this basically did was, you have a file which, when it rotates inside the canal at a fast speed, because of the friction, it dissolves the GP. This gutta percha, after dissolving, will obviously flow. We use this property of the gutta percha for bringing out three-dimensional obturation. And then there are core carrier-based obturation systems. I'll show you pictures to make it more clear what carrier-based obturation systems are. There are chemoplasticized obturation systems where you dip your gutta percha into a gutta percha solvent for a few seconds. You take it out. So this gutta percha point is soft. Then you can introduce this inside the canal. Because it is soft, it flows into the lateral anatomy very effectively. Then there are apical barrier techniques in which you only obturate the apical third of the root canal. Most common material for the apical barrier technique is MTA, or mineral trioxide aggregate. We'll see that as well. Now, out of all of these techniques, the techniques which are used commonly are only these, and that is why we are only going to discuss these in detail. Let's see cold lateral compaction. When I talk of cold lateral compaction, the technique is extremely simple. You use a master gutta percha point. You take a spreader. You try to insert the spreader as deep as possible, preferably within 1 millimeter of the working length. The moment you remove the spreader out, you will be putting some accessory gutta percha inside. Then you take an instrument, which is a heat source, and you seal it at the orifice. That's how simple cold lateral compaction can be. However, there are several disadvantages with this technique. One disadvantage is because of the massive force that you need to put onto the spreader, there are chances that the tooth gets vertically fractured. Another disadvantage is, see, what you're doing actually in lateral compaction is you're filling your canals like this. But there are still dead spaces between these GP points. Ideally, your root canal obturation after lateral compaction should have been something like this. But that does not happen. Let us see this in a dental scenario. This tooth has been obturated using lateral condensation technique. The obturation looks fairly good. It looks fairly dense in the apical third, middle third, coronal third, everywhere. But when you take an angulated radiograph, when you turn this tooth completely sideways and you take a mesiodistal radiograph for this tooth, you can see the kind of dead space present inside this root canal. This happens especially when a tooth has an ovoid or conical cross section. It will not happen very frequently in round canals, but it's very common in oval canals, which is why lateral condensation is becoming less and less of a favorite. Because in lateral condensation, always you will leave out some amount of the tooth structure not obturated. So they came up with thermoplastic or 3D obturation techniques. Now, when you talk of three-dimensional obturation techniques, there are some things that you require. Lateral condensation can probably not give you a three-dimensional fill. So what exactly do you need for a 3D obturation? You need to perform extremely good irrigation. You need to activate your irrigants, and you need to have a fantastic preparation of the root canal system. How are we going to achieve this? Let's see that. Let's talk a little bit about the irrigation protocol and the irrigants that are to be used. What happens is, this is the kind of anatomy that you see in your root canals. With this anatomy, what happens is, because there is so many anastomoses, there are isthmi, there are apical deltas. Like in this particular maxillary molar, it's difficult to even count the number of root canals. There may be somewhere close to 6 canals probably, but you can never be sure because there is so much of interaction between different root canals. Filling all of these with just gutta percha or filling them with just lateral condensation is close to impossible, which is why we rely on our irrigants. Your irrigants can enter these spaces. They can dissolve the pulp tissue in these spaces. Once the pulp tissue is dissolved, it is easier for your thermoplastic gutta percha to flow in these intricacies. So what irrigants do you really use when you are performing endodontics? There are only 4 irrigants that you need. You need 5% of sodium hypochlorite throughout your instrumentation. You need 17% aqueous EDTA, that is the EDTA solution that you get. This is, mind you, this is different from the EDTA that you use along with your files, the RC Help, RC Prep, Glide. These formulations are EDTA with carbamide peroxide or EDTA with urea peroxide. What I am talking about is an aqueous solution of EDTA right now. This needs to be activated for 1 minute. You also use chlorhexidine in some cases. Chlorhexidine is to be used in cases where you have a lot of infection in the periapical area, or whenever you're doing a re-endodontic treatment, and you use saline or sterile water between two irrigants, so that these irrigants don't come in contact with each other, so that they don't interact with each other. Now, when I talk about activation of irrigants, the kind of activation that is most accepted as of date is ultrasonic activation. Whenever you're performing ultrasonic activation or ultrasonic agitation of your irrigants, there are two phenomena that occur inside the root canal: cavitation and acoustic streaming. I'm sure you are all aware about this because we were thoroughly taught cavitation and acoustic streaming in periodontics. Now, the thing that I'm talking about, why is ultrasonic activation better, is basically because if you are using a sonic activator, there are studies that have shown that if you don't use ultrasonic, there is no cavitation inside the canal. And if there is no cavitation, the particular activation technique that you use has no antimicrobial efficacy whatsoever. Because of which it is amply said now that you need to use an activator which has ultrasonic properties, because sonic alone is not sufficient. It's very clear in this obturation picture, if you can see. Whenever you perform regular irrigation, a lot of the root canal area is left as dead space, or it is filled with dentinal debris. However, if you activate the irrigants using your ultrasonic activator, you get perfect three-dimensional fill of the root canal. So here in the prerequisites, we can easily see that it is extremely important to activate the irrigants with an ultrasonic activator. So let's discuss what kind of irrigation protocol you need to follow whenever you're performing endodontics. This is not restricted to a particular type of obturation technique or a particular type of case. This is a universal irrigation protocol which I have been following, and it has been working well for me. Throughout your instrumentation, you will only use 5% sodium hypochlorite for irrigation. There should be no saline, no sterile water on your tray. Only sodium hypochlorite. Once you have taken your master cone radiograph and you are ready to obturate, you will rinse the canal with sterile water or saline, and you will use 17% EDTA. This EDTA needs to be ultrasonically activated for 1 minute. Once this is done, you again rinse it off with sterile water or saline. One more time, you will use the same 5% sodium hypochlorite, but this time you will activate it for 30 seconds. These both steps, activation of EDTA and activation of sodium hypochlorite, are extremely important for three-dimensional fills. After you have activated the sodium hypochlorite, you will just flush with sterile water or saline. You have an alternate step of irrigating with chlorhexidine at the end, which can be left in the canal for 2 minutes, and then you can straight away proceed for obturation. Or in teeth which are heavily infected, you will use the same chlorhexidine as an intracanal medicament, and you will leave it inside the canal. So to gain good results, to gain a three-dimensional fill, like here you can see we've filled a lateral canal. In this case, you can see we've filled an apical delta or a lateral canal. There is sealer in the PDL space as well. To get these kind of obturations, following this irrigation protocol is extremely important. Now that we've discussed about the irrigants, let's talk about the steps to follow during the root canal to have good three-dimensional obturation. Just in short, you need to have a straight line axis. You have to locate your canals using a 10 number K file. When I talk locate canals, I mean only locate the canals. Only put your files in the canal till about 12 to 13 millimeters. Till wherever it goes very easily. You don't need to go till the apex at all. Once you have located the canals, you will use your orifice shaper files, your orifice wideners. You may be using one flare, you may be using endo flare, you may be using SX. Whatever you're using, you use that orifice shaper for enlarging the coronal third. What happens because of this is there is more space available for accommodating a higher volume of the irrigant that you are using. More the irrigant, better the tissue dissolution inside the canal. After using the orifice shaper, you will use the same 10 number K files, but this time you will go right up till the apex and you will determine the working length. Extremely important to note is that Working length is always determined after the coronal flaring is complete. Please keep this in mind. After you have established the working length, you will prepare a glide path either using manual files or rotary files, and only then do you move to your rotary instruments. Once rotary instrumentation is done, you can go to your same steps of cone fit radiograph, tuck back, application of sealer, and finally obturation. So whenever you are performing three-dimensional obturation, it becomes extremely important to have a good set of hand pluggers. Now these hand pluggers, if you take a good set of hand pluggers, they will have one end which will be made out of nickel titanium, which will help the plugger to go inside deep, even in curved canals. And the other end will be made out of stainless steel, because these stainless steel tips have more stiffness and you can use it for packing the middle and the coronal third. Whereas the nickel titanium end can be used in the apical third. That's why the nickel titanium end is always given slightly smaller than the stainless steel end. Now let's talk about the different techniques of three-dimensional obturation. Now the first method that I want to talk about is the core carrier based obturation. What happens in the core carrier based obturation is, these are what you see here in these three pictures. These are gutta percha points. These gutta percha points are, they come with a handle, and there is a core in between, which is also called as the carrier. This is pre-marked at 18, 19, 20, 22, 24. The reason there is a core carrier in between is because this gutta percha that is present on the surface can be softened by heating it. And then you can put this carrier inside. The carrier may either be made of metal or plastic. Once you have carried it inside the canal, you just need to cut the carrier at the orifice. Once you have cut the carrier at the orifice, the seal inside the canal will be extremely good. What you need to note here is the thickness of this carrier is always going to be greater than the number that is mentioned on the carrier, or greater than the master apical file that you have used. That's why they always come with a set of verifiers. So if I have prepared my canal till 30 number file, I can take a 30 sized verifier to see if a 30 numbered core carrier will easily go inside the root canal or not, right? Because once this GP point is becomes thermoplastic, the carrier can enter the canal more easily. How do you heat these carriers now? There are different kinds of ovens which are available. The systems are called Therma-prep, Therma-fill, Simply-fill, Gutta core, etc. What these ovens basically do is, see, this is a core carrier that has been kept. I just need to press onto this button. Once I press on this button, the core carrier goes inside the oven. In the oven, there is controlled heating of the gutta percha on the core carrier. What I do then is, this is my verifier inside the canal. It fits snugly inside the canal. This is my core carrier which has been heated. I start pushing it inside. I will adjust my stopper to my working length so I know when to stop. Once I am sure that my stopper has reached the coronal reference point, I will stop inserting this inside the canal, which means I would have reached the apex of the root canal. Then I will just take a heated instrument if I'm using a plastic carrier, or I will have to use a rotary instrument like a burr if I have a metal carrier inside, and I will seal it off. These days, all carriers that are available are either made of plastic or they are made of gutta percha itself, stiff gutta percha. So that's how you seal it, and this gives you fantastic three-dimensional filling. The problem with this technique is, sometimes what happens is you may not get, you may waste gutta percha points, because when you have heated it and when you insert it inside the canal, the carrier may be stripped of the gutta percha and only carrier may be left. So you realize that there is a lot of dead space in the obturation. This especially happens when you are starting your, when you are new with this particular technique. So, and you cannot basically afford to waste these GP points because they are expensive. So they also turn out to be a higher cost for you whenever you have a particular molar which has 4 or 5 canals. The cost of obturation greatly increases. Plus, you need to invest in the oven. Another disadvantage is, or I'll say rather another precaution that you need to take is, when you are inserting the core carrier inside the canal, don't ever twist or rotate it. Just slowly you need to straight push it up till the apex. If you rotate or twist it, same thing will happen. The gutta percha will be stripped from the surface and there will be a lot of dead space in your obturations. So after this, after the core carrier based obturation, I want to talk to you about a very simple means of obturating, that is the cold flowable obturation. What exactly this means is we don't have many products available. The most popular one obviously is Gutaflow 2, which is from Cold Team. Now, this Gutaflow 2 is basically a sealer in which they have also incorporated gutta percha particles. What you need to do is you inject this sealer inside the root canal, which is why we call it a flowable obturation system. And then you just take one master cone, insert in the canal till the full working length and seal it. Because the sealer also has gutta percha particles and your GP point also has gutta percha particles, it becomes kind of a monoblock. There is good adaptation. Plus, because this is flowable, it can flow into all the accessory anatomy and it can bring about good quality of obturation. The disadvantages, if I were to enumerate for Gutaflow 2 or for a cold flowable system, is you tend to waste a lot of this sealer. Because it's an auto-mix type of syringe, the amount of wastage is higher. Another disadvantage is that this sets extremely fast. So you need to be really quick when you're putting it inside the canal. You can't afford to waste time. Now, after we discuss the cold flowable obturation, let's discuss hot flowable obturation. What I basically mean by hot flowable obturation, a lot of doctors also call it as squirt obturation or squirting obturation. These kind of guns are available, which are called as backfill guns or backpack guns. You put a gutta percha pellet here, and the gutta percha pellet is heated inside the gun. The moment you start injecting, hot gutta percha comes out and you can fill the canal with that. We'll have a short video when we discuss the continuous wave condensation, so this will become much more clearer. The primary disadvantage of squirting obturation is that there is no apical control. Because you are only injecting gutta percha inside, there is no control over the apical third. Then another technique called the warm vertical compaction, very simple. In warm vertical compaction, we used to do, what we used to do was we used to take a heat source and seal the gutta percha and heat the gutta percha to a deeper level. We used to proceed step by step. First the coronal third, then the middle third, then the apical third. Once the apical gutta percha is sheared off, only the apical 4-5 millimeters of GP will be left. Then you take a cold plugger and condense it. Now here you had to go step by step, so it used to take a lot of time. So we modified this technique and we came up with something called continuous wave compaction. What you do in continuous wave compaction is, in a single stroke, you go right up till the apical third and you seal the GP. Then you take a cold plugger and you condense the gutta percha. Don't get confused. The video will make it much more clearer. This is the kind of system that you will require for continuous wave condensation. This unit is called an EQV, which is from Metabiomed, like you can see. EQV is a set of two devices. The first device is called the down pack. The down pack, what it does is, with this down pack, you obturate the apical third of the canal. With the backfill, you obturate the middle and the coronal thirds of the canal. How? Let's see in the video. You will take gutta percha points which will match the master apical file that you had used. So with these master gutta percha points, you will confirm the tuck back. Your gutta percha point should be 0.5 to 1 millimeter short of the apex. You will take appropriately fitting hand pluggers. These hand pluggers should be good quality and you need to pre-select them and see that they reach the apical 5 or 6 millimeters. Similarly, you will take a tip to attach to the down pack unit. This tip also needs to correspond with the size of your gutta percha. Adjust the rubber stopper on the tip according to the working length. It should be 5 to 6 millimeters short of the working length. Mix sealer. Take a little bit of sealer on your gutta percha point. Gently pump the gutta percha point inside and then insert the GP till the full depth. Once you have done this, you use your down pack unit, put it on, heat it to a temperature of 180 or 230 degrees Celsius. There is a button on the down pack unit which you need to press. Once you press this button, heating starts. If you can see in the picture, with the heat, we've just removed the excess gutta percha which is above the orifice. Once this excess gutta percha is removed, we will start using the same tip and going deeper inside the canal. Once I have reached my stopper, which was adjusted 5 to 6 millimeters short of the working length, I will keep this tip inside for another 5 to 10 seconds. After that, I will just activate it for 1 to 2 seconds and I will pull the tip out. The reason for these 1 to 2 seconds is so that the entire gutta percha from the apical third does not get pulled out. The next instrument I used is my condenser, that is my plugger. I plug the apical third of the root canal, and this is how my apical obturation is complete. The next unit I use is my backfill unit. This backfill unit is the gun that I had shown you. There are GP pellets available which you insert inside the gun. You start the heating of the gun by pressing the buttons there. The GP starts going inside your needle. Once it has gone in this cartridge, it starts getting heated. A blinking light on the unit of the EQV shows that heating is going on. Once the light is stable, bright, it means that heating has been accomplished. Once heating is accomplished, you will carry this gun inside the root canal. You will keep it in contact with the apical gutta percha for 4 to 5 seconds because you want to soften the apical gutta percha so that all of this becomes a single unit. Then you start injecting by pressing the plunger on the gun. You will fill 3 to 4 millimeters, remove the gun outside. You will take the same plugger that you had used and you will condense this soft gutta percha. Once this is done, you repeat the same process, take the gun again, backfill a little bit more, take the next plugger and condense the gutta percha. That's how simple obturations can be. The primary advantage of using a system like this over something like thermofill or a core carrier based obturation is when you use a continuous wave condensation technique, the cost of obturation reduces greatly because this gutta percha is not expensive. Plus, this obturation is much quicker. Although in the video it looked like it took a very long time, you will not take more than 15 or 20 seconds per root canal. As of date, the universally most accepted technique for obturation is continuous wave condensation. It is not any other technique right now. So please make sure to invest in these kind of units so that you can perform three-dimensional obturations adequately. So, okay, I don't want to invest in this unit, but I still want to perform three-dimensional obturations. What option do I have? So there was something called as thermo-mechanical obturation that we discussed a little while back, where I told you that you use something like a max pattern compactor. Now, a slight modification of a max pattern compactor is this file that you see here. This file is called as a Revo condenser, which is available from Micromega. If you look at the flutes of this instrument, they are very similar to an H file. The only difference is that the direction of these flutes is completely opposite of that of an H file. So when you use an H file, all the debris and pulp tissue from the canal are coming out. Whenever you use this condenser, all the gutta percha is getting pushed inside. So of course, I need to tell you how to use this condenser and what are its advantages. I love this particular device, especially when I'm on consultations and I cannot use continuous wave condensation because I cannot carry my unit everywhere. I use thermo-mechanical compaction. The condenser, which is the Revo condenser, is what we'll be using. So you take a gutta percha point which is coated with sealer. You put this Revo condenser in your contra-angle handpiece, which is attached to a micromotor. We will rotate it at a speed of about 3 to 5,000 RPM in a clockwise direction. This is extremely important because if you rotate it in an anti-clockwise direction, the condenser will get sucked inside the canal and there are high chances of separation. If you are careful, the condenser will never separate. Okay, so what happens is when you rotate it at such a high speed in a clockwise direction is, it exerts a lot of pressure on your gutta percha. There is a lot of friction between this condenser and the gutta percha. Because of the friction, the gutta percha gets plasticized. Because of the plasticity, the gutta percha gets pushed into the lateral anatomy. Now you just need to use accessory gutta percha points and you can complete your obturation. This is a very easy means and the most cost-effective method of doing three-dimensional obturations. So now I will be attending to a few case scenarios, particularly two. One is going to be the management of open apices. How do you obturate these cases? And the second is the obturation of C-shaped root canals. So talking of management of open apices or blunderbuss canals, there are basically three methods of managing it. First one is basically outdated now, where we used to use repeated dressings of calcium hydroxide to bring about apexification. Every 3 months we used to change the dressing, and we used to hope that apical barrier will be formed, but the success was limited and the amount of time taken was very high. Plus, there were a lot of cases where fractures were happening because of the use of calcium hydroxide for such a long time. So then we started using something called as tailor-made gutta percha, which looks something like this. If the patient cannot afford the use of mineral trioxide aggregate, you can make a thick GP point, put it inside the canal and seal it off. There are, however, several risks involved with this. This GP point cannot snugly fit all the areas of the root canal. Like if you can see in the apical third, I can see some dead space around the apical portion of the gutta percha point. Now, this dead space could mean failure of the case eventually. So I do not prefer to use this. The most preferred method for management of open apices for me is the use of MTA. When you talk of MTA, MTA or mineral trioxide aggregate is an extremely biocompatible cement, which can be used for many different kinds of procedures. Today, we are only talking of obturation of open apices. Although mineral trioxide aggregate can also be used for regular root canal obturations. There are several brands available, like you can see in this picture. The means for using MTA in the canal is extremely simple. Once your root canal has been prepared and cleaned thoroughly, completely, what you do is you will take an MTA carrier, introduce the carrier inside the root canal. I just want to tell you here that the MTA carrier that I use most frequently for anterior teeth is nothing but a lumbar puncture needle or a spinal anesthesia needle that you can get at any pharmacy. The only thing you need to do is you need to cut the spinal anesthesia needle to a shorter length, and you load the spinal anesthesia needle with MTA. It's very similar to the use of an amalgam carrier. It's exactly the same thing for you. You will load it with MTA. You will dispense the MTA inside the canal. Now, for taking this MTA to the apical third, it is preferable that you don't use a metallic instrument. You should preferably use a paper point or a gutta percha point, because our intention is not to condense the MTA. It is just to place the MTA and tap it into place. The difference is when you condense this MTA, it becomes a thick mass, but the moisture of the MTA is lost. Because this moisture is lost, setting of the MTA is disturbed. Mineral trioxide aggregate basically sets because of moisture. Now, if the moisture is lost, the setting is not predictable. So always what we'll be using is we'll use a gutta percha point to carry the MTA to the apical third and then to tap it into place. Once the apical third is obturated, you may need to introduce some more mineral trioxide aggregate inside the canal, exactly in the same way that we did for the first increment. Once these two increments are done, the apical obturation is complete. The apical barrier is formed, and this works well even if you have a wide open apex. Once this is done, you only need to use your backfill gun for filling the rest of the canal. But there should be a time difference of 24 hours between these two procedures, because MTA will take approximately 8 to 12 hours to set. So it's preferable that you put a moist cotton pellet inside the canal, give a temporary restoration on top, and send the patient home. So in practice, this is how the lumbar puncture or the spinal anesthesia needle will look. We'll introduce it inside the pulp chamber, inside the root canal. Then we'll use a gutta percha for tapping the mineral trioxide aggregate inside. This is one case which was done with MTA, where I had filled this lateral incisor with MTA, but the canine and the central incisor were plain gutta percha. You can see the amount of healing we have achieved in 6 months. Another case where I had done apexification with MTA. I have a 7-year follow-up for this, and looks like we have achieved complete healing of the periapical lesion. Although this tooth, we had our own doubts whether the tooth will last for a very long time or not. One more case where there was a wide, large periapical lesion associated with the maxillary central and lateral incisors. We have placed MTA in the central incisor, whereas the lateral incisor is just plain gutta percha obturation again. and you can see the amount of healing that we've achieved in only 3 months of time. So what I want to tell you is that mineral dioxide aggregate works fantastic when you want to do apexification. Dr. Roxon, if you are with me on this line, can you please put up this poll? My next question to all of you is, if you have a particular tooth, well, like, can you leave a endodontically treated tooth without an obturation? You know, this is what I started my presentation with. Can a tooth be left without an obturation after endo treatment has been performed? I'll just exit the presentation for a little while and I'll see your answers. I want to see how many of you all say yes, how many of you all say no. We will stop sharing the screen, and 93% say that we cannot leave these teeth without obturating. Okay, 90%. There are still about 10%, 12% people who are saying that we can leave a tooth without an obturation. Very good. I'll just access these results. Just going through your messages. Lot of highs, good mornings. Thank you very much, everyone. Very good morning to all of you. I have a lot of my seniors with me here. I have a few friends from outside India here. Thank you very much for being around. I have very senior endodontists here, which is really a pleasure for me. And there are some few questions which I will want to address to at the end. I'm still waiting for a few more answers from you. Yeah, so coming back to the polls, the results I have right now is approximately 16% people say that you can leave a tooth without obturation after performing endodontic treatment, whereas close to 83-84% are saying that you cannot leave it without an obturation. So let's see what exactly I am talking about when I'm asking this question to you. Let's go to this beautiful procedure called pulp revascularization. Although this may sound like something straight outside of a science fiction movie, pulp revascularization is not really that new. People have been trying it. It has been under research since many years, and I can confidently tell you that this is a procedure that you can practically perform inside your clinic right now. The only catch here is that the case selection is extremely critical. What happens in pulp revascularization is, let's say you have a patient with a wide open apex. This is an immature tooth. The apex is completely open. The apical area of the tooth has stem cells. These stem cells are called stem cells of apical papilla, or SCAP, SCAP. When you have these stem cells of apical papilla, what you do is, these stem cells of apical papilla are extremely potent, and they can differentiate into odontogenic cells. What I mean by this is, these odontogenic cells inside the root canals can lead to continuation of the formation of the root in two terms. First, it can increase the length of the root. Second, it can also add diameter to the dentin. So basically, the root canal diameter decreases. How do you achieve this? Let's see this in short. I want to first discuss about the case selection, because case selection is the most important point. People who want, you all can take a picture of this slide. You all can take a snapshot of this slide. When you talk of case selection, the most important point in case selection is, you need to have a patient who is young age. You cannot have a patient who has gone. I am sorry, just one moment. I just got a message that I've forgotten to share my screen. So here, I'll just go back to you. I'm extremely sorry about this. Yeah, I hope I'm with you now. So we will just repeat the last couple of slides that we discussed. I forgot to share the screen. So yeah, coming to revascularization of the pulp. Now, this technique, like I told you, has been in use since a very long time. What I mean by pulp revascularization is this procedure. This is a tooth which has a wide open apex. There are stem cells which are present in the apical area. These brown tissue that you see here are the stem cells. These stem cells have the potential to differentiate into odontogenic cells, that is tooth forming cells. These are called as stem cells of the apical papilla. After the procedure that we perform, which is called the revascularization procedure, what happens is these stem cells enter inside the canal, and because of the odontogenic nature, they can bring about increase in length of the root. Once the length of the root is increased, they can also bring about increase in the thickness of the radicular dentin. So the diameter of the root canal reduces. This has several advantages because the length is increasing. The strength of the tooth or the retention of the tooth inside the bone is also going to improve. And because of in a decrease in the diameter of the root canal and increase in the diameter of the radicular dentin, the tooth tends to become stronger. So it can accept more forces. So let's come to the selection of the case. What exactly is required when we talk about pulp revascularization? The primary requirement is that your patient must be young. What I mean by this is a patient who has already crossed the age of 14 or 15, you should not be attempting this procedure. So the ideal case is a young boy who is say about 10, 12 years of age, who had suffered trauma 3-4 years back when he was 7-year-old or 8-year-old. Because of the trauma, the tooth has never been able to form completely, and now the patient is coming to you. So you must think about performing pulp revascularization. Another ideal case, as per me, is a young mandibular or maxillary molar for a patient who is about 9 or 10-year-old with a huge cavity in that particular molar. You often see that the apex is wide open. These cases also are ideal for performing pulp revascularization. You need to be sure that the tooth has sufficient structure left and you don't need to put a post and core, because if you remember the procedure, you don't have any space to put a post because there is an MTA seal that we are going to put here. Your patient must be very cooperative and should be ready to come to you for routine follow-ups, because follow-ups are extremely important. You must be sure that the apex is wide open. Slightly wide apex is not okay. We need an apex which is more than 100 number 5 in diameter. So it's a really wide apex. You should inform the patient that you will need to come multiple times, so he should be ready for that, and you should also accept to him all the alternative treatments that you have. Any doubts about this procedure? I'll put up my phone number at the end. Please feel free to WhatsApp me. I'll try to send you whatever is possible from my end. Now, how do you perform this procedure? Extremely simple. Let me tell you, this procedure is 100 times simpler compared to a regular root canal that you're doing. And it gives you predictable results. So let's look at this. Let's see the first appointment. You give anesthesia to the patient. You perform rubber dam isolation. You perform access opening. Do not introduce any instruments inside the root canal. Perform copious gentle irrigation with sodium hypochlorite followed by saline. Dry your canals with paper points. Make a mix of triple antibiotic paste. Place it inside the root canal as a dressing. Seal the canal with a temporary restoration and then put glass ionomer cement on top. Why glass ionomer cement? Because we are going to leave it for 3 weeks. One question that I think that you all may have in your mind is, what exactly is this triple antibiotic paste? So triple antibiotic paste is a mix of metronidazole, minocycline, and ciprofloxacin. These 3 antibiotics combined together are known as triple antibiotic paste. It becomes a powder. You have to mix this powder with saline or chlorhexidine or with propylene glycol, and you introduce it inside the canal. Once this is done, you dismiss the patient for the next 3 weeks. Let's see what you do after 3 weeks. When the patient reports back to you after 3 weeks, you will check the signs and symptoms that the patient has. Most cases, your patient will feel completely comfortable. The swelling or pain would have completely gone away. I want you to notice that in the first appointment, we have not done any instrumentation at all. We have not used a single file. We have only irrigated the canals thoroughly and we have placed a dressing in the canal. In the second appointment, if we realize that the patient is completely asymptomatic, we will use anesthesia without a vasoconstrictor. Why without a vasoconstrictor? Because this appointment, we want to induce some bleeding inside the root canal. If you use a vasoconstrictor, the bleeding will not be there and your canal will not be filled with blood. See, the entire idea is, I'm just going back to the previous slide. When you have this particular picture, these stem cells of apical papilla, I put a file from here once and I disturb the stem cells of apical papilla. These stem cells will come inside the canal along with the blood, right? This blood will get clot like this. Now this clot will have some stem cells suspended in the entire matrix or in the entire scaffold. Because of this, it is these stem cells that are going to bring about formation of the dentin. So I'm not going to use any vasoconstrictor here. I will take a single file, take it beyond the apex, and I will bring about bleeding, or I will basically stimulate bleeding from the periapical tissues. I will take a small cotton pellet to arrest the bleeding about 2 to 3 millimeters apical to the CEJ. Once the bleeding has arrested and a clot has formed inside the root canal, I will mix mineral trioxide aggregate, which is MTA, and I will place it like this as a coronal barrier. After this, I will place some glass ionomer cement and a permanent composite restoration. Did you get the procedure? Here for this MTA, I do not need to place a moist cotton pellet because this bleeding will have moisture. The moisture will help the MTA to set. Here we have written GIC or MTA because that was what was given in the guidelines in 2013. But MTA is the material of choice for this procedure. Is this procedure successful? It is extremely successful. When you take a patient on follow-up, you will see that the patient does not have any pain, any soft tissue swelling. As you keep taking the patient on follow-ups, in a few months, you will see that the periapical radiolucency has also completely disappeared and that the length and the width of the root are increasing. So the tooth is becoming as close to normal as possible. The only thing is you should always inform your patient in a few months or in a few years, if we realize that we need to perform endodontic treatment for this tooth, we will be doing a regular root canal treatment. That's all that may be needed. It will be very easy to perform it because this might be the scenario after a couple of years. Maybe the patient will report to you with pain. You need to drill through the composite, through the glass ionomer cement. You need to drill out the MTA coronal barrier that you had put, and you will find a canal which will have some tissue which will be similar to pulp. Now, when we talk of obturations, we also need to talk about sealer puffs because these sealer puffs are something that have become extremely popular, especially because of social media. What we see in these sealer puffs is that there is a lot of sealer that comes out of the canal. You see tiny balls around the canal, around the apical third of the root. These sealer puffs are generally present in the periapical area. What happens because of these sealer puffs is, now you may have a question, should I try to achieve a sealer puff? My answer to that would be no. However, there are some endodontists who feel that a sealer puff is the only way to be sure that your working length estimation was correct. What I feel is if you have used your apex locator correctly, you can always be sure of the working length. Why do I say that you should not try to achieve a sealer puff? Because whenever you get a puff of sealer in the apical third of the root, what happens is this causes some amount of pain to the patient. There is also local necrosis that occurs in this periapical area. So the next 2 to 3 days or maybe up to 5 days, the patient will feel some pain. And sometimes you may perform overzealous pumping of the sealer, which may give you results which may be similar to this. There have been numerous case reports where sealer has entered into the trabecular pattern of the bone, or sometimes sealer has entered the mandibular canal. It has brought about paresthesia of the mandibular nerve. So what I'll advise is don't try to get a sealer puff. If it comes, well and good. If not, please don't put in any extra effort to intentionally get a puff of sealer. Let's see another type of case that is a C-shaped canal. Now, these cases have a very complex anatomy. The canal is basically in the form of a C. This is what it looks like to you when you do an axis opening. So I'll explain to you with a case. This is a mandibular second molar that I was treating. Now, when I saw the radiograph, I was almost certain that this will be a C-shaped canal. How? C-shaped canals are most common in mandibular second molars. Secondly, the mesial and the distal root seem to fuse with each other. Third point is I have one large distal canal, but my mesial canal seems to disappear in the coronal or the middle third. Then we perform an access opening and we realize that this is a true C-shaped canal. The mesiobuccal canal, which is this here, and the distal canal are fusing with each other, and my mesiolingual canal is separate. Now, because of this large intercommunication between the canals, the amount of pulp tissue is also massive. Your irrigation has to be very, very thorough. Your shaping has to be circumferential inside the canal. This is a working length radiograph that I took. This is my master cone radiograph. This is my final obturation. Now, if I were to perform this obturation using lateral compaction, I would have never got a good seal. I would have always left some dead space inside the canal, which is why what I used here was continuous wave condensation. And this is the final obturation that you see. So please remember, thermoplastic obturations are absolutely mandatory whenever you have a C-shaped canal. Now the thing to see here is that this single GP that you see here is my mesiolingual canal. This thick gutta percha here, the thick obturation in the distal that you see is actually the mesiobuccal and the distal canal, which are intercommunicating with each other. Please always have tremendous faith in the root canals that you're performing, because endo can give you the kind of healing that you can never even expect out of it. Just routine non-surgical endodontics with a good three-dimensional cleaning and shaping, and then a three-dimensional fill. Always remember, if your irrigant has not reached a particular portion of the root canal, your obturating materials can never reach that part of the root canal. So give maximum importance to three-dimensional cleaning and shaping, and then to your 3D obturation. We are open to questions now. I want to thank the Group Pharmaceuticals company and the Dental Reach. Group Pharmaceuticals have basically initiated this entire process, and Dental Reach has brought about entire coordination for this fantastic webinar. They have a beautiful platform here using Webinar Jam. Dr. Roxon from Dental Reach has been taking a lot of effort, making some fantastic promotional material, which was beautiful. And then he's also made sure that everything goes across in a timely manner. The kind of communication that he has had with me, the kind of trials that we have had, it has all been beautiful. I would urge you all to like the Dental Reach community on Facebook as well. I would like to thank Mr. Binod Vidyarthi, who is from Group Pharmaceuticals. He was the one who had approached me for this webinar. I am very much available to you all for all questions now. I will just exit the screen share so that we can access these questions that you all have put across. So screen share is off. I have a lot of questions. Let me start accessing some questions that were in the past. So yeah, the first question that I had received was, when do you obturate the tooth when you have an endoperio lesion? Fantastic question here. I will obturate my tooth, or rather, let me just take an endoperio lesion, for example, mandibular first molar with a true endoperio lesion. I always perform the endo first before going in for the perio. I start the endo first is what I mean. I open the tooth, I complete my cleaning and shaping. After completing the cleaning shaping, what we do is we give an intracanal dressing. My dressing is essentially going to be a mix of calcium hydroxide powder and chlorhexidine liquid in these cases. I will leave the dressing inside for 2 weeks. In these 2 weeks, I will ask my periodontist to perform the periodontal treatment which is required. And once the 2 weeks are completed, if we have dry canals, we'll be obturating them. Next is, but ZOE-based sealers are cancer-inducing, which studies have suggested. Well, Dr. Renu, what happens with ZOE-based sealers are some ZOE-based sealers which have components like formaldehyde preparations similar to paraformaldehyde. They are carcinogenic. For example, endomethasone, even AH26 had some components which were which are not present in the new AH plus now. So only if you have these kind of cancer-inducing agents inside your ZOE, it will be carcinogenic. Otherwise, it will not. Which solvent can be used to remove a resin-based sealer? You have solvents which are specifically meant for dissolving resins. Just one second. There is something called as Gutasolve R. There is also a solvent available from Septodont, which is specially meant for dissolving these resin sealants. I'm sorry, I can't remember the name, but I'm sure it is a resin dissolving solvent from Septodont. So you can just check with your dealer as to the availability. So yeah, screen down. Finish. Which is the chemoplasticized material? Well, you just need to put in your gutta percha points inside your GP solvent, your regular GP solvents. You can use xylene, you can use chloroform. So these kind of solvents basically will help you to soften the gutta percha, and then you can use this gutta percha inside the canal. I have only used the chemoplastic obturation method during my college days, and I have never actually incorporated it into my private practice. In case of a draining sinus, which kind of sealer should be used? Well, you know, the draining sinus is not going to dictate the kind of sealer that you are going to use. The only difference here is going to be, because this particular case is heavily infected, I will prefer a bioceramic sealer. But I also want to make a point here that bioceramic sealers are pretty expensive. So it may not be prudent for every practitioner to use a bioceramic sealer for every infected case. So for these cases, you can easily use a zinc oxide eugenol based sealers. You will have good results of healing. Is it true that chlorhexidine has to be removed after irrigation? How do we ensure that it is completely removed? No, you don't need to remove chlorhexidine after your irrigation cycle. Chlorhexidine can be left inside the canal as your final rinse. You do not need to remove this chlorhexidine from the canal at all. The pluggers displayed in the presentation are from which company? Well, these pluggers are they are called as EQ pluggers, which is what I have been using in my practice since a couple of years now. They are from Meta Biomed. These pluggers are available with Bombay Dental, who is the distributor for these pluggers locally. Dr. Ankit Shah is asking, can affect the result of apex locator after use of sodium hypochlorite? Well, all the new apex locators, that is the 5th and 6th generation apex locators that we are using right now, the irrigant of choice or the medium that should be left inside the root canal when you're performing when you're performing working length estimation using an apex locator, the irrigant of choice is sodium hypochlorite. So, well, your question was, does sodium hypochlorite affect the accuracy? Well, it affects the accuracy in a positive way. The accuracy is improved. Another question is, which company is marketing the kind of nickel titanium stainless steel hand pluggers shown here? I've already told you, Bombay Dental is marketing these. They are manufactured by Meta Biomed, which is a Korean company. Dr. Apeksha Mulya is asking, can this be used in curved canals? I think she is asking about the same pluggers. Well, because these pluggers have a nickel titanium end, they can be used very safely in curved canals as well. Dr. Kurian is asking, cold flowable obturation sets in how much time? So if you go by the literature that is given by the manufacturer, they say that you should wait for 5 to 6 minutes before you proceed with packing the tooth and completing the obturation. If you talk of the sealer, when you're carrying the sealer along with your gutta percha point, or if you're injecting the sealer slowly inside your root canal, you don't have more than 1 to 2 minutes of working time. So working time is quite short, but setting time is adequate. You can wait for a few minutes before you set the entire, before you proceed with the entire obturation. The Dr. Kurian is also asking the cost of the EQV machine. Well, doctor, I don't know the exact cost right now, but there has been a massive decrease in the cost, because when I had purchased the unit, I had paid close to 1,10,000 rupees. And right now, if I am correct, it is close to 85,000. Dr. Minaz Asha's question is, what if the gutta percha comes out with the heated instrument in case of warm vertical compaction? Dr. Minaz Asha, this is a fantastic question. It's very beautiful. Because when I started my warm vertical compactions and continuous wave compactions, this used to happen very frequently with me. So the answer to this is, if the GP comes out, you have to take a fresh GP point and re-obturate. But I can tell you a short way of making sure that the gutta percha does not come out. What you do is, after you have put the gutta percha, after you have sealed it, don't be in a hurry to remove your downpack unit. Keep it inside for about 10 seconds till the unit completely cools down. Please listen carefully. After this tip has cooled down in 8 to 10 seconds, press the button one more time for 1 to 2 seconds only, wiggle it slightly and pull it out. If you follow this method, very rarely ever will the gutta percha get pulled out. But obviously, it's absolutely mandatory that you have good tuck back. If your tuck back is not good, there is a high chance that the gutta percha can either come out or it will get pushed in the periapical tissues. Dr. Peksha Mulya has asked, is there any problem if MTA extrudes beyond the apex? Dr. Peksha, the good news is that how much ever MTA extrudes beyond the apex, it will never create a problem for you. So you can be assured that MTA getting pushed beyond the apex is not going to create any kind of problems for you. Next question, Dr. Disha Sankhe. There are quite a lot of questions. Okay, let me take a few of them at least. Sorry, yeah. Dr. Disha Sankhe is asking, what is your opinion about the seal bio concept? Dr. Disha, the concept is very promising by itself. The only question that I have in mind is there is not adequate research yet. So for a research point of view, it is fantastic, but for clinical practice, I think we will have to wait a little bit more. So Dr. Manisha has put up a fantastic point. My dad's tooth has lasted 18 years after cleaning and shaping without obturation. So yes, Dr. Manisha, there are a lot of researchers who are trying non-obturation endodontic techniques, and very often this stays okay. There is Dr. Naseem from AIMS or Maulana Azad. I think she's from Maulana Azad, who has been publishing a lot of articles about non-obturation endodontic techniques, and she has got good results. But the number of articles that support obturation are definitely higher. Till the day we don't have a definitive non-obturation endodontic technique, we will still prefer to perform three-dimensional obturations. There are a lot of messages that they could not see my slide, and I once again want to apologize. I forgot to put on the screen share. Another question is, if you irrigate with sodium hypochlorite, then will you harm the radicular pulp with young open apex teeth? This is a debatable topic. The most consensus that I have found is that you should use a 3% chloride, sodium hypochlorite, rather than using a 5% sodium hypochlorite. But there are enough number of articles which have said that if you are going to use a side vented needle, using full concentration sodium hypochlorite is also okay. There are a couple of questions. Please repeat the antibiotics which are required in a triple antibiotic paste. The antibiotics for a triple antibiotic paste are metronidazole, minocycline, and ciprofloxacin. Those who want to know how to make this triple antibiotic paste, I'm just typing down my number in the comment section. You feel free to send across a WhatsApp to me. I will send the entire protocol for preparing triple antibiotic paste. Dr. Vaishali Machi has asked, what if the bleeding is uncontrolled in the pulp revascularization technique? Dr. Vaishali, this will not happen because the bleeding that you are inducing is of very small quantity. Plus, we are using a small cotton pellet to arrest the bleeding. It will not take more than 3 to 4 minutes for the bleeding to get arrested. It will not be uncontrolled bleeding from the root canal. In case you feel that the bleeding is more than what you had expected, you can take a cotton pellet, dip it in concentrated sodium hypochlorite, and then you can use it in the pulp chamber. That's absolutely okay. What if you're not able to stop the bleeding? I've discussed this. How to control hypo from going beyond open apex? I've discussed this. Use a side vented needle. So, okay, the organizers, I think Dr. Roxon has shared the Facebook link. This webinar will be available for the next 24 hours. I am just resharing this link in the comments. Dr. Roxon, if you could just reshare the link in the comments so it comes at the top. You can share this link with your friends in case they need to access the webinar again. There is a long question. This scenario is similar to periapical pathology like periapical periodontitis or granuloma, where one of the root will be vital. Whether the tooth be without a lesion at the preparation, later I will develop sensitivity. similar to a periapical granule or periapical stem cells within the canal is totally a different scene. Well, yeah, if there is a possibility in teeth which have multi roots, that is more than one root. There are studies where they treat only one root, but this is not given predictable success so far. So I'll say please don't perform selective root canal treatment. Like, I know that there is a lesion in the distal root and the mesial roots are vital pulp. I cannot perform endodontic treatment only on the distal root. I have to perform endodontic treatment completely. In revascularization, how do you ensure that the bleeding is from scap and not remnant pulp bleeding? When you have performed sufficient irrigation with sodium hypochlorite and you have given a dressing of triple antibiotic paste for 3 weeks, you can be sure that there will be no pulp left inside the root canal. Because these are wide root canals, the pulp gets washed out extremely easily from the canal. Thank you, Dr. Harsh. Thank you very much, Dr. Nupur. Thank you, Dr. Disha. Which sealer do I recommend? I have 3 criteria. Whenever I am performing routine endodontic procedure, I will use a zinc oxide eugenol based sealer. The sealer that I prefer the most is Pulp Canal Sealer EWT. Whenever I am performing endodontic treatment in which I am going to require a fiber post at the end, I use a resin based sealer. I use AH Plus in my practice, the resin based sealer. And whenever I see a large periapical lesion or I see signs of resorption inside the canal, I see or I'm doing a re-endodontic treatment, I see any unusual anatomy, if there is a perforation in the canal. So any complex root canal treatment, I use bioceramic sealer, and the bioceramic sealer that I use is Gutaflow BioSeal, which is from Colty. How to fill lateral canals? Dr. Arshi. Hi, Dr. Arshi. She is asking, how do I fill lateral canals? The procedure is extremely simple. You don't need to do anything separately. If you have performed 3-dimensional cleaning and shaping, if you are performing activation of your irrigants, your lateral canals will get filled automatically. You will not need to perform any separate procedure. Could you please explain why we should not use EDTA while instrumentation, as it will help in removing more inorganic matter? Dr. Anupriya, I did not say that you should not use EDTA gel during your procedure. The only thing I said was for the irrigation and activation, you should use aqueous EDTA. In my practice, I use EDTA gel with my hand files, that is with my K files, and after my K files are done, I keep my pulp chamber completely filled with sodium hypochlorite, and I use my rotary files only with the sodium hypochlorite. I'm sorry, yeah. So how to fill accessory canals, and thank you, Kotnis sir. Should we use EDTA gel? I've just covered this. What are blunderbuss canals? Dr. Pandey, blunderbuss canals are exactly wide canals with a very open apex. You can just go to Google and search what is a blunderbuss pistol or a blunderbuss revolver. You will get your answer. Thank you everyone for your fantastic feedback. I'm really happy with this feedback. Sometimes only one canal is non-vital. Is it possible to do obturation of only one canal? I already said you cannot do that. If over obturation, yeah, Dr. Arindam Patra has asked a very relevant point. In case over obturation occurs due to warm vertical compaction, then should we do condensation or not? And should we remove it or should we leave it to observe? Whenever you are performing warm vertical compaction or continuous wave condensation, it is not possible to retrieve your obturation with an H file. In most cases, it will be extremely difficult to pull out the obturation very easily. So in case there is over obturation, just leave it as it is. Don't perform any additional procedure. Just complete your obturation, give a seal over the tooth. Because you have performed good cleaning and shaping, the patient will not have any symptoms because of this over obturation. How short should we keep the tip in case of down pack? Okay, your down pack tip should be about 5 to 6 millimeters short of the working length. This was asked by Dr. Anupriya Badoria. What is my opinion about hemisection, Dr. Jain? Hemisection is one procedure where case selection is a little critical, but the results are fantastic. So anytime you have a tooth in which, let's see, there is a instrument which has separated beyond the apex, and the tooth is symptomatic after a few months or a few years, hemisection may be your treatment of choice. Okay, Dr. Roxy. Yeah, I think I have answered most of the questions. In case you use Gutaflow BioSeal, can you use single cone as its bioceramic? Fantastic question, Dr. Jimit Bamania. I want to tell all of you that because everyone loves single cone obturations, bioceramic sealers are the only kind of sealers in which it is okay for performing single cone obturation. You can safely perform single cone obturation if you are using a bioceramic sealer. I hope all of you all are very happy with this last answer that I have provided, because everyone loves to perform single cone obturations. Get your hands on any bioceramic sealer from a good company, and you can safely perform single cone obturations. I would like to give a big thank you to all of you once again. I am extremely happy that we had an interactive session. Dr. Roxin, thank you so much for coordinating the section beautifully. Dr. Nupur, thanks for taking care of the back end along with Dr. Roxin. Many thanks to all of the participants for giving your time. We will end the live session here. In case of any questions, please feel free to shoot them up at me a little later. In case there were questions that I have not answered because of shortness of time, I know it's lunchtime for a lot of y'all, so I will leave y'all here. In case there's any reason, please shoot me up on private chat. Thanks a lot, all of you. It was great interacting with all of you here, and many thanks to Group Pharmaceuticals for doing the entire session here. Thanks a lot.